Good morning. First of all, I'd like to thank Professor Patrick Marcelin and all the committee for the kind invitation. That's the 5th time I'm here, and it's the first time here in the plenary session, and it's a great pleasure to talk about the current management of NASH. So the most common liver disease in Western countries is non-alcoholic fatty liver disease. It's an hepatic manifestation of metabolic syndrome with a very high world prevalence. It can vary from 6% to almost 50%, and it's almost universal in patients with severe obesity. The major factors related with non-alcoholic fat disease are obesity, type 2 diabetes, and metabolic syndrome. When we look for the NAFLD clinical scenarios, it's important to think that we can have a patient in our outpatient clinics with just steatosis, but this patient can progress and have NASH. And then we have to take care. Our goal in this patient is reduce to progression to cirrhosis. It's really important to do that. When you think about a patient with NASH, you think about a patient that can have problems, cardiovascular disease, mainly cardiovascular disease, can have cancer, can have rarely HCC. But when the patient moves to cirrhosis, he progresses to cirrhosis, he can have also liver-related complications. What it's completely different, and we will have to manage another different thing. So our goal, our build in this case, is to reduce the progression to cirrhosis. It's what we have to think when we see a patient with NASH. But the question is very difficult, the work is very difficult because we don't have any approved and miracle drug to change this profile and to stop the disease. We have to propose, the first thing we have to propose to our patient is diet and lifestyle changes. It's not easy, all of us know that, all of us see this kind of patient in our consultation. We have to propose it to someone that's most of the time obese or overweight to start to do exercise and to do a diet. It's really complicated, but it's the most important thing. It's the first thing, it's for everybody, and it's the most important thing. Because when the patient weight loss, he have many benefits. When we look, for example, a patient that was submitted for bariatric surgery, he has a reduction of the circulation volume, the risk of atrial fibrillation and heart failure, obstructive apnea, that is a huge problem in this population. We have a decrease in leptin levels and insulin resistance and incidence of diabetes, also hypertension, dyslipidemia. We have a change in the gut microbiotes. We have a better GLP-1 levels. We have also more possibility to do physical activity. Most of these patients have many problems to do exercises, so when they are they are not obese or they lose weight, they can do more often exercises. And one also very important point that we do not sometimes pay a lot of attention is about the psychosocial stress. This patient frequently is a depressive patient, an anxious patient, and when he starts to lose weight, he can interact better with the environment, he can have better opportunities to socialize. It's much better for his life, for his quality of life. So I was talking about the completely individual, but when we look for the liver disease, weight loss, even if he just loses 3 to 5% of his weight, we can have a remission of steatosis in more than 50% of the cases. When he loses 7 to 10% of their weight, they can reduce NASH score parameters, and when he has more than 10% of his weight, he can also have NASH remission, and also fibrosis regression. As Professor Bedosat just said here, fibrosis is a very important thing, even if it's not part of NASH. It's a really important thing because fibrosis is closely related to worse outcomes, to complications, and then when we have fibrosis remission, it's for us the most important thing. One of these works that I just showed, it's this work that shows the effect of combined diet and exercise for 48 weeks in a population. And then what we could see, it's a steatosis improvement with a minimal weight loss, but inflammation in ballooning was just appearing when the patient have a loss of weight that's over 70%. And in this study, there is no effect on fibrosis, on liver fibrosis. But it's important to say that they have modifications in ballooning and inflammation that are parameters of NASH. These two works shows the impact of Mediterranean diets. We have many diets. If you talk with a patient that's overweight, he did many of them. If you look in the internet or even in the medical articles, we have many kind of diets. But Mediterranean diet applied in a population that have the habit to have this kind of diet can have some positive effects. In the first work, they compared this study with here with the reduced fat controlled diet and the Mediterranean diet with an extra doses of extra virgin oil or nuts. And so the incidence of acute myocardial infarction, stroke, and death were lower than the patients that just received the reduced fat diet. The same thing occurred for incidence of diabetes. We can see that patients with this kind of diet have lower in diabetes than the patients that received the reduced fat diet. The EASL guidelines suggest this kind of diet. It's not a Bible, but we can use that for patients that have the habit to have and propose that for our patients to help them to lose weight. Of course, also we should propose them to do exercises if they could. This work shows the results of a program, a controlled program, aerobic exercise program of 12 weeks for 29 teenagers, 15 of them obese and 14 lean patients. But we can see a reduce in subcutaneous fat diet, visceral fat, hepatic fat, and intramucosal fat, showing that, of course, it's not a program that we should do just for 12 weeks, but showing the impact that exercise can have in the population. Of course, they are teenagers, they can do 12 weeks of exercises. Someone can do 12 weeks of exercise. It's a program that we should put for life for a patient, but showing the impact of just 12 weeks in the fat. This systematic review of 28 randomized clinical trials shows the effect of physical activity on hepatic liver fat. And you can see that it was more prominent in young patients and patients with a higher BMI. So they lose more than the others, but it's again showing the important role that exercises have in these patients. Maintaining weight loss is a challenging. Everybody knows sometimes the patient can even lose weight, but maintaining the lose weight, it's completely different. Here are some studies that shows the mean change from baseline here in brown to the end of the diet. But after we can see from a follow-up range from 4 to 7 years that the mean change from baseline for follow-up are different. So it's difficult to maintain the weight loss. It's difficult to make this patient continue, but it's important. We have to support, to take care of these patients and try to make them maintain this weight loss. In our experience, in 540 patients in our outpatient clinic in Rio, we have almost 50% with a multidisciplinary access, physicians, nurses, and diabetologists, and nutritionists. We have almost 50% of them that gained weight, that increased their weight since the beginning, less than 10% of the total with a reduction over 7%, and just 7% have maintained their weight. So it's a real challenge for us, but we have to try to make that because it makes a real difference. When we do not achieve that, we can also think to use drugs to management the obesity. These are some of the drugs that were proposed. The approved drug that we use is the GLP-1 receptor agonists that have a potential for cardiometabolic and liver benefits. As you can show here, we can see that in this article published in 2016, we had, comparing liraglutide to placebo, a resolution of NASH, ballooning, and inflammation, and we have better fibrosis in patients that took liraglutide than in those that received placebo. Of course, it's an important drug for lose weight, not for treat NASH, but it's some kind of drug that we can use and can help us to manage our patients. Also, GLP-1 agonists reduce all causes of mortality, hospitalization for heart failure, and improve renal status in patients with diabetes. We have lots of patients with diabetes. Of course, we know that the progression and the disease is different in this group of patients that have diabetes than in those without diabetes. So they have a benefit using this kind of drug also. But we have to think also about bariatric surgery. So we have the diet and lifestyle changes, diet, exercises. Sometimes we can use drugs, and maybe if the patient is not responding, we can try bariatric surgery. It's not a magic approach. Sometimes we take a look and we see that patients are talking about wanting to do that, but it's not a magical solution, and we have to really select our patients. Even if we have really good results in some publics, we have to think that patients with severe liver disease, with severe fibrosis, F3 and F4, in the post-operatorium period may have, some article shows that they may have an increase in the liver fibrosis. That's a real problem. And also, it's an addiction. Sometimes patients eat because they have an addiction or they have a problem. And when you take it off, maybe this patient will have another kind of addiction. They will change their addiction. They will consume more alcohol, sometimes other kind of drugs. A recent paper showed that we have more suicides in these patients. So we have to do, it's not against bariatric surgery, but we have to do a very good selection to see which patients could be benefit from that. We see more reversal, we see more difference in patients with lower degrees of fibrosis. It's more benefit. So we have to choose each case to be sure to give the best for our patient. And so, which would be the best candidate for pharmacological treatment? Even if we don't have a miracle drug, we have some drugs that we can use. We are not treating all the patients. If you look, for example, ISO guideline, we are treating these patients with fibrosis F2. We have to select them to use what we have. These are some of the randomized studies with pioglitazone and compared with the placebo. So they included patients with or without diabetes, 30 to 45 milligrams daily. And so we can look that most of them, the pioglitazone, all of them, sorry, have a better result than the placebo in the reduction of NAS score. Vitamin E, that was for much of us that was dead and we are not using. We have this recent paper that shows that vitamin E improves transplant-free survival and the compensation in patients with advanced liver fibrosis, F3 and F4. Here we can see the transplant-free survival was different in patients that received vitamin E than in compared controls. And also we can see the benefits in hepatic decompensation in those who received vitamin E in comparison with those controls. Diabetes is a real problem in NAFLD patients. The risk of incidence in diabetes was significantly associated with NAFLD. So I'm telling it because in these patients we very often use metformin. It's a first-line drug in the treatment of diabetes and prevention of pre-diabetes progression. No proven benefits in histological parameters, but there are a retrospective study that shows an anti-tumor effect with limited human data. And the last thing is about statin. We have this study that shows that using statin in these patients, we have a benefit in all the parameters, even some histological parameters, but ALT, AST, laboratorial parameters also. We see that we are underusing statin in our patients, and it's an important drug in NAFLD patients that we should consider, and all the papers showed that we have less risk than we thought in the beginnings. So my take-home messages are that NAFLD is a highly prevalent liver disease, as everybody knows. There is no approved drugs to manage it till now. We have many coming, many trials, many clinical trials, but we don't have an approved drug for that. Diet and lifestyle changes are essential in these patients. Pioglitazone and vitamin A are still they play a role in this group of patients, and statins are underused in our NAFLD patients. We should take more care of that and use more often because it's an important drug. Thank you very much.